Good morning, everyone, and good afternoon or good evening, depending on where you're joining from. Our two experts, it's late afternoon, almost early evening. Welcome to another PINE event. And for those who haven't joined before, the PINE is the Pulmonary Infection Network of Experts for the American Thoracic Society. It was created by the Pulmonary Infections and TB Early Career Professionals Working Group. The goal with PINE is to highlight a different pulmonary infection each month in an interactive format with experts in the field to hopefully give insight into said infection, or in this case, complication of an infection. I'm Jerry Zifodya. I'm your host. I'm Associate Professor of Medicine at Tulane University. We are joined today by Mansi Chaturvedi. She is a PGY7 Pulmonary Fellow at the University of Maryland, and she's kindly provided us with the case that we'll be going over today. Our experts today will be Professor Brian Allwood. He's a professor and consultant pulmonologist in the Division of Pulmonology, Department of Medicine, and Faculty of Medicine and Health Sciences. He's both at Stellenbosch University in South Africa and Cape Town and the Western Cape government. And our other expert, who we are also excited to have, is Dr. Celso Khosa. He is a director at the Centro de Investigação e Triemo, Saúde da Palano Canico, or CISPOC, at the INS Ministry of Health in Mozambique. Both experts have published extensively in post-tuberculosis lung disease, and we're truly, truly honored and excited to have them be our discussants with discussing post-TB lung disease. That being said, Mansi, please take it away.
Hi, everyone. As Jerry mentioned, my name is Mansi Chaturvedi. I am one of the fellows from University of Maryland, and today we are going to talk about the aftermath of microbiologic cure of tuberculosis, a case of post-TB lung disease. So starting with the session objectives today, we are going to review a case of pulmonary TB with multiple post-TB sequelae. We are going to go over PTLD definition, prevalence, and epidemiology. And then we are going to discuss the potential drivers of lung injury in TB and in post-TB lung disease. And at the end, we are going to review PTLD management strategies, including prevention and treatment with emphasis on host-directed therapies. So our case today is that of a 42-year-old female, originally from China, who moved to the United States in 2016. She has history of drug-sensitive pulmonary TB in 2008 that was treated with 6 months of RIPE therapy. And now she presents with productive cough and weight loss for 2 months. Because her AFB smear is positive, she's empirically started on RIPE therapy due to concern for recurrent drug-sensitive TB. And eventually, her drug sensitivities show that, unfortunately, she has extensively drug-resistant TB, and she is then started on initially on oral and injectable regimen, and later switched to BPAL once the regimen is available to her. This is her CT scan at initial presentation with XDR TB diagnosis to us. And here you can see that she has consolidation in the left upper lobe and multiple cavitary lesions in bilateral upper lobes as well as in the left lower lobe. She achieves culture conversion at 4 months after starting the appropriate therapy and is treated for a duration of 2 years. And 6 months after finishing therapy, she comes for a follow-up and reports that she has residual dry cough and chest tightness with mild exertion. She does not have any fever, chills, weight loss, or night sweats, and her sputum cultures do not show any organisms. And these are her longitudinal CT scans over time. And this is mostly to show our audience that compared to her initial XDR TB diagnosis, she does have significant improvement in her CT scan, especially post-therapy, as you can see. However, even 6 months post-therapy, we can see that she has residual scarring in her lungs, especially on the left side, as well as right upper lobe cavitary lesion that has persisted even after finishing therapy. And this is a trend of her PFT and 6-minute walk test over time. And we can see that 6 months into therapy, she has severe obstruction with air trapping. And as she progresses with treatment, we also note on her lung volumes that she now has mild restriction as well as moderately reduced DLCO, which has persisted even post-therapy. And on her 6-minute walk test, she does have significant desaturation intermittently, not to the point that she is requiring oxygen, but she does desat when she ambulates. So we can put up the poll for the first question here for our audience, which is, how is post-TB lung disease defined? Option 1 is any persistent respiratory symptom or radiographic abnormality occurring during or after TB treatment. Option 2 is chronic respiratory abnormality with or without symptoms that can, at least in part, be linked to past TB episode. Option 3 is bronchiectasis in a person with suspicion of prior TB. And option 4 is delayed sputum conversion in a patient currently on TB therapy. So I'll give our audience a few seconds to respond here.
They picked your option. 71% of people who polled picked your option 2, which is chronic respiratory abnormality with or without symptoms.
Okay, perfect. So that is the right answer, which is great that most people answered it correctly. I have 2 questions for our experts here. The first one is that what do you think are the pros and cons of this definition? And the second one is, how do you apply this definition of post-TB lung disease in a clinical versus research setting?
Yeah, we can start with Prof. Brian and then Celso. Dr. Khosa, please proceed afterwards.
Yeah, okay. So this definition we put together in 2019 as part of the first TB symposium using the Delphi process, and it was never meant to be the final definition of post-TB lung disease. It was, at the time, we didn't have any idea what it had a really rough. There was just no epidemiological data on post-TB lung disease. So when we analyzed all of this, we wanted to put together a definition that was very sensitive, but not necessarily very specific, because we were concerned that cases were being missed in the community and in epidemiological surveys, etc., etc. And so just to break it down, why some of the discussions which we had at the time, it had to be chronic symptoms. Okay, so the symptoms couldn't be acutely related to TB. They had to be ongoing, and you'll notice we didn't put time frames to any of these things. Okay, with or without symptoms. So the reason why we said with or without symptoms, we had a long discussion about this, is that if you have a really bad abnormality on your chest x-ray, your lung function, you're not sure what the epidemiological outcome of that is. It's a little bit like having a high blood pressure. If your blood pressure is 190 over 110, you don't feel anything, but your outcomes are actually worse. So that's why we said with or without symptoms. And then this, at least in part, attributable to previous episode of TB. Why that was important is that post-TB can be super added into any other condition. So we often see it, for example, in minors who've got silicosis, they get TB. But the major component may be the silicosis and it may be the post-TB lung disease, but you've got to account for that. And if you say it's only silicosis, you're going to totally underestimate the burden of post-TB lung disease. Similarly with COPD, similarly with ILD, sarcoidosis, etc., etc. So that's what that was the construction. It was never meant to be a sensitive, specific definition. It was always meant to be sensitive for epidemiological reasons. And certainly in clinical practice, often we'll see patients who've got this disease who will have classic feature. You'll have, say, example, a garden variety silicosis or a garden variety COPD, but then they'll get TB and then they'll have post-TB fibrosis. And so they'll have these two disease burdens superimposed on each other. And you got to be aware of that. Clearly, it's got a lot of cons. The granularity of the definition is not tight enough. The time frames, the symptoms, the past definition. And the other thing that I would like to say is you need to hold on very lightly to this definition because in the next couple of weeks, I think in the next 2 or 3 weeks, the research definition is going to be released, which I'm sure you've seen presentations on already. And again, the problem with that definition is it's highly specific, but not very sensitive. And so the truth will lie between, depending on what study you're going to have, will lie between those. Yeah, that's my opening comment on this.
Yeah, thank you, Brian. Celso, are you using this definition, or how are you defining people with PTLD in your clinical practice? And then does this definition help, in your opinion, from your practice?
Yes, I think as Brian said, this kind of very broad definition, and from the beginning, you don't need. I mean, you can have like functional or even symptoms or even quality of life factors inside definition. So it allows you, even in the most remote settings, to at least catch these patients, and then you can work from there to better define and have granularity. So I think what we see in our settings, for example, is that our post-TB patients, they are very young. They would have a median age of 31, 32. So basically what happens is that most of them will have structural or functional changes, but not related to symptoms subjectively, because most of the times when you ask them, they will tell you they are okay, they can run. But most of them, what they do usually is they compensate their lung impairment with the other systems because they are still young. So basically, the older they get, they start to have respiratory symptoms because they can no longer compensate. So that's, I think, I also think that this definition somehow is also very good because allow us, even in limited resources settings, to capture part of the patients. And of course, with more research and more data, I think we will be able to improve this definition.
That's fantastic. Thank you. Mansi, you can proceed.
All right. Well, thank you, everyone. Okay, so we already went over the definition. I want to mention for our audience here that as many as 25 to 50% of our patients with pulmonary tuberculosis keep suffering from respiratory symptoms even after microbiologic eradication of the infection, just showing the high burden of post-TB lung disease. And multiple risk factors have been implicated in the pathogenesis of post-TB lung disease, including pathogen factors such as pathogen burden, virulence, and drug resistance, host factors such as cellular injury and regeneration pathways, profibrotic pathways, delay in diagnosis, such as in our patient, as well as genetic factors. And of course, environmental factors such as smoking, biomass fuel exposure, and air pollution, and occupational exposure like silica in our mine workers. These are recent trends of TB cases and deaths from the WHO tuberculosis report. And I really want to gather your attention to the graph on the left side here, which shows that since about 2020, there has been increase in the number of incident TB cases worldwide, which is thought to be in the setting of COVID-19 pandemic. And if you look at the number of deaths since 2020, they have more or less remained stable. And this is to show that if the number of incident cases keep going up while we have stable mortality, we are more and more likely to see patients with post-TB sequelae in our clinical practice in the coming years. This is data from a study that was published in the Blue Journal this year, looking at cases of TB in the United States between 2015 and 2019. And the authors here used modeling analysis and found that up to 41% of the patients had total life years lost post-TB, and nearly 48% of the patients had quality adjusted life years lost because of post-TB, highlighting how important it is to prevent lung damage post-TB cure. As many of you will know, there are multiple clinical phenotypes of post-TB lung disease, including airway disease such as COPD and bronchiectasis, parenchymal disease such as fibrosis, cavitation, and atelectasis, as well as pleural thickening, and pulmonary vascular disease such as pulmonary hypertension. So my next question for our audience here, and we can put up the poll again, is what best explains the heterogeneity in radiographic patterns of post-PTLD within the same patient population? Option 1 is differences in MTB strain virulence alone. Option 2 is uniform pattern of fibrosis in PTLD is present regardless of host factors. Option 3 is variability in bacterial host and treatment factors. And option 4 is presence of drug-resistant versus drug-sensitive TB alone.
While the audience is answering, I'll ask Celso to begin with. In terms of the patients that you're taking care of, we're going to end the poll in just a little bit. How many of them are you actually getting imaging on at the end of TB treatment? Is this a common practice? Do you think it should be a common practice? What are your thoughts?
Thank you, Jared. So routinely, we don't perform imaging at the end of TB treatment. And in terms of availability, for example, in Mozambique, we have 35 million people, and we might have something like 10 CT scans. So it's really, CT scans is a resource that is impossible almost in just very specific cases. What we have available is like chest X-rays, but also is not easy in a country with this burden of TB. Is not easy to get those. So basically, very few patients, unless they have a clinical indication, will get a X-ray at the end of TB treatment, and that's one of the possibilities to have to evaluate structural damage provoked by TB. So I would say that we need to find a tool that allows us to evaluate patients at the end of TB treatment. I'm not sure if radiology would be the most appropriate one, but also we see advanced in radiology like portable X-rays and things like that might help. But simpler tools like questionnaires or effort evaluations might be more adequate for our setting.
That's fantastic. It's helpful also to get an insight also as to the practicalities of some of these potential screening modalities. Mansi, that's really helpful, Celso. Thank you. Mansi, for your answer, 88% of respondents responded with variability in bacterial host and treatment factors.
All right, great. So that is the correct answer. I wanted to ask our experts here if they could talk about how differences in lung injury across the PTLD spectrum makes it a challenging disease to study in a research setting, but also to treat in a clinical setting.
I'll open that up to Brian.
Oh, I was gonna thought you were gonna ask that up for Celso. Damn, man. This is a really good question, a really difficult question. I mean, just what struck me about your case, Mansi, is just look at the resolution of your CT scan from acute, what looked like devastating total fibrosis of particularly that left upper lobe, and then kind of it disappears largely, or so we think. And so there are huge differences. which make it, you start with a study and you end with a treat. But if it's difficult to study, it's difficult to treat, isn't it? Because the problem with post TB is it's like a fruit salad. You're trying to treat a fruit salad. And some patients have airflow obstruction, as you point out. Some patients have pleural disease. Some patients have just total destruction. Some patients have nothing. The majority of patients actually have very little or nothing, if you look at it statistically. But the patients who are affected are often young and previously healthy, and it's a disaster. So, this is one of the problems with the challenge with the spectrum of disease being so broad. And one of the massive cautions that you got to say is that when people are designing studies, particularly if they're not pulmonologists. Obviously, this is an ATS program, so most people are going to be pulmonologists. But if you don't appreciate the complexity of your disease, you're going to get negative studies. Everything is not going to be beneficial. And it's a little bit like the ICU studies, which for year after year after year come out as negative studies because you're treating pancreatitis and a trauma pig victims with the same broad brushstrokes, and they're not the same disease condition. So I think it is incredibly challenging. That said, there are certain things that we can do, and I can pick up again. I'm keen to hear Celso's comments, and I can pick up again afterwards if you want.
Well, I mean, this I would say also again an interesting question. At least in our setting, I think looking at these three factors, we first look at comorbidities. For example, HIV in this case, but also diabetes will have a lot of influence on how is the whole process or the disease process in different patients. The other factor that I think we also consider many times is the lineage. When you look at, for example, M. bovis versus M. africanum, or even lineage 1 versus lineage 4, in terms of inflammation at the host, you'll see a different pattern. So this will lead again to a different injury along the lung, and then to a different pattern. And as Brian said, this is a salad. You'll find people with big changes of abnormality in the lung when you look at the CT scan or X-ray, but no symptoms, and people with symptoms but no changes, and then spirometry. So I think something that maybe we'll discuss, having in this case phenotypes will help a lot in the future to address each type of patient. Ben?
And just to say, Mansi, why at the get-go at the first symposium we actually proposed many of those phenotypes, those airways, the small airways, the large airways of fibrosis. Why we proposed those is that we wanted people to be aware that it's not just one thing. Just because your FEV1 is low doesn't mean you have the same clinical phenotype. And the problem with calling things phenotypes is that it has to have a clinically meaningful difference. So either it's got to be genetically different, or it's got to have some kind of presentation difference, or it's got to have some kind of outcome difference or treatment difference. So we hesitate to use the term phenotypes in post-TB because we don't have the epidemiological data to back that up. And that's why you'll see in many of the publications you specifically use the term clinical pattern, because we don't know what it means. They may all be the same in the end, but we don't know. So Celso is absolutely right, and it's really is. You've got to be quite nuanced when you think about your patients, and you almost have to have an N=1 approach, even in your research setting.
Just to add one thing, one other factor that I think it's also important is the environment. For example, in our setting, because of cultural reasons, we see that, for example, women usually cook, so they will usually be exposed to other injuries to the lung, like indoor pollutions with biomass. So that will also impact in the final pattern you see in terms of abnormalities.
That is really helpful and insightful, and it sounds like it is complicated, is what I'm hearing. Essen Kweruem, who has done a lot of the studies in children, adds to that complication by saying this is even more challenging in children or with different TB phenotypes across the pediatric spectrum. And I think I think everyone on this call would agree that that just adds another level of complexity. Children are not small adults. It's very, very different TB in children. So, Essen, thank you for that comment. I see someone has their hand up. For the audience. If you have any questions, please feel free to type them out. We are more than happy to, well, actually, we have John Kondawani. I'll allow you. You can please go ahead. You can unmute. We'll let you ask your question. But for the audience, please do type your questions into the chat. We'll try to address all of them. John, please go on.
Thanks. Yeah, thanks, Jerry, and thank you, Mansi, for this wonderful presentation, and thanks to the experts also and Brian for their insights. I think just to the expert question, I just wanted to add a bit of perspective from my end. I'm from Zambia. And of course, it's very difficult coming from LIMC setting to manage this this condition for the purposes that Brian and Celso have said. So these clinical patterns are different, and I think if you look at your patient that was presented, there was evolution in the pattern from start to finish. So I think the variability is not just in a particular patient, but I think from time to time there's that variability. So whereas at one time point a patient may have this clinical pattern, at the end, maybe 3, 4, 5 months later, it may be different. But of course, the aim always in terms of trying to alleviate patients' symptoms and reduce morbidity and maybe mortality is to look for what are called treatable traits in respiratory medicine. So for a particular patient, what is a treatable trait? If, for instance, they have an aspergilloma as a result of post-TB lung disease, that's a treatable trait. You can treat. If they have an obstructive pattern, perhaps you can treat with bronchodilators, depending on reversibility and so on. However, the challenge I face in my setting, I think maybe as many others from this part of the world, is that to get to a treatable trait, you need diagnostics, and diagnostics are not always available. What was presented was advanced imaging with what I think I gather is higher res CT, good modality, but not available everywhere. So to get to know that this is a particular clinical pattern and radiological pattern, you need the CT, and you'll not be always able to get it. To get a trait like an obstructive pattern, you need spirometry, and you may not get spirometry in all settings. So there's a difficulty in terms of you may diagnose and say, okay, likely this is a post-TB lung disease, but you may not really, and you may have an idea clinically what clinical pattern the patient may have, but to confirm it is also another thing. So you're left sometimes just presumptively managing this patient for a trait that may or may not be there. I think that's what I wanted to add to the brilliant insights I've gotten from here. Thank you.
Thanks, John. Thank you very much. Excellent, Mansi. Let's move on. There's more to the case.
Yeah.
And
Well, thank you, everyone.
And there's questions in the chat. We're going to try to address these as we go on, and I'll try to find slots for the experts to respond to those. Mansi, please go on.
All right. Okay. Well, I think this discussion nicely brings us to this slide, which is key areas of interest in PTLD pathogenesis, where the authors have highlighted clinical factors, some of which were brought up, such as obesity, diabetes, HIV, microbiologic factors such as MTB burden and antigen, but then also host immune related factors. And we will discuss some of this as we talk about host directed therapies towards the end of this presentation. So more on that. So coming back to our patient, the patient comes back for a 2-year follow-up now. She reports that she has persistent dry cough and shortness of breath, now at rest, which worsens with exertion. You get a repeat set of PFTs, and she still has moderate obstruction and mild restriction, suggestive of a mixed pattern with air trapping and mildly reduced DLCO as well. And this is again, her CT scan 2 years after therapy, which, as before, shows persistent fibrotic changes, as well as some mild bronchiectatic changes. So the next question I have for our audience here is, what is the most common abnormality on spirometry seen in patients with post-TB lung disease? First is obstructive pattern, second is restrictive, third is mixed pattern, and four is varies by study type and region. So we can have the poll.
Well, while the audience is responding, Brian, I'll pick on Celso first on the next question. However, I would love your thoughts on spirometry as a diagnostic modality in your setting and in other settings where TB is common.
Yeah. Sure. You do like the can of worms, don't you, Jerry? So spirometry is spirometry, and it measures lung volumes. It measures lung volumes against time, and that's nice. But spirometry is not foolproof, and it has a lot of problems. The one problem that you have is it has to be done by people who are well trained, and people often forget that, especially people who are maybe non-pulmonologists, especially people who are new to the field, and pretty much ubiquitously, everybody does their first spirometry study as an epidemiological study and ends up throwing out about 40% of the spiromograms because they're not actually of acceptable quality. And so that's the first thing. Spirometry has to be done to an acceptable quality, and that's not a small thing, because your spirometer has to be validated. In the States, you guys have got a lot of lung technologists. We've got quite a few in South Africa, but outside of South Africa, it's difficult to find well-trained spirometers. And the Pan-African Thoracic Society, in collaboration with ATS, have done fantastic work in terms of getting training out. And Lindsay Zerber particularly has done a lot of work in this field and has really expanded it. And she's done a fantastic job in getting that, because people think it's easy to do, but it's not. So that's the first problem, the problem with the test itself. The second problem is, the question is, what does it actually mean? In some cases, it means a lot. So there's quite a good correlation between spirometry and functional capacity. Now, I noticed, Mansi, and I was going to ask you a question, throw a question back to Mansi. In your initial spirometry, I think I had it right. At about the first treatment point, the FEV1, FVC was somewhere in the 40% predicted, yet she could still walk 550 meters. Now, that's quite impressive to me, to be able to walk 550 meters with an FEV1 of FVC of 40%, or in the 40s. And so we don't actually, Jerry, know what these things all mean and how they fit together. Certainly on an epidemiological basis, if you look at the whole population, the lower your lung function, the more likely you are to have symptoms, and the more likely you are to have poor outcomes in terms of mortality, etc. We know that on a population level. But on an individual patient level at the bedside, it can be far harder. And I think you're opening a can of worms, because the question you're fundamentally asking is, if we know it's a good test and we know it's reliable, we know the outcomes are fantastic, then everybody must be doing it. But should we be promoting that everybody does it if we don't know that it's a brilliant test? And that becomes a little bit of a can of worms that you're answering. Certainly at the moment in 2025, it's probably one of the best tests we have. And so I wouldn't chuck it out, but certainly we need to actually validate it and make sure that actually what we promote actually has got a good body of science behind it.
That is fantastic. And thank you for answering a difficult question, because I think a lot of us are struggling with that. Mansi, in terms of audience response, this is the most mixed of responses. We have 12% saying obstruction, 20% saying restrictive pattern, 48% saying mixed pattern, and 20% saying varies by study type and setting. You can continue.
Thank you. Yeah, I think that's very interesting. And as I read more about post-TB spirometry studies, I think one of the things is that it's impressive how much the answers vary depending on the study and depending on the region of the study. So it's what we have really found is that it really varies, and which is what brings me to our expert question is, why do you think there is such variability between spirometry studies? And then the second question is, as clinicians, when and how often would you recommend performing spirometry in patients with post-TB lung disease? Do you perform it at certain intervals, or do you mostly go by patient symptoms?
Dr. Khosa. Please
Okay,
go.
thank you. I think it's interesting that when I was doing my PhD and doing spirometry in following up patients post TB, I would find mostly restriction or low FEV. And being at the start of the PhD and looking at other papers and seeing just obstruction and mixed, I was very worried about my results and the validity of it. So, I mean, what we see, and because the pathophysiology of the disease, we also have a lot of factors. We see that it really varies depending on the region, but also on the studies. I would say the first factor I would look is how is spirometry being done in that study specifically, post bronchodilator, what are the reference values being used, how are people doing that? So this question of validation of the test, but also of the interpretation, I think is really important. But from the other side, we also see that in the clinical field, that patients have a different pattern of disease, as we said. And when we look, for example, younger population versus older population, you see that in younger populations, you see a little bit more of low FVC, and in older population, you see a little bit more of obstruction. So all of these will influence in the type of lesion or abnormality you see on spirometry.
That's fantastic, Celso. Yeah, I think as we all read more and more, we really find there's just such variability also by some of the regions that some of the studies are coming out of. Brian, to put you on the spot, a follow-up question in the chat that I think is very pertinent to this. And people, please keep putting your questions in the chat. We're going to leave some time at the end to answer some of these. But one that I think is pertinent is from Jotam Paspanojga. And I want to ask you, Brian, do you think the minimally clinically important difference in FEV1 in post-TB is the same as that of other diseases? As in, should we be using this FEV1 the minimal clinically important FEV1 that we use in other lung diseases such as COPD?
Yeah, the short answer is we don't know. We really don't know. This is one of the things that we're actually looking at the moment with our current research project. So hopefully, maybe in a year's time, we can at least partially answer this question. But you asked the question, how often should you be performing spirometry in patients? And yeah. So well, let me pick it up again. So we don't know what the minimally clinically important difference is in FEV1, and we need to know what that is. We also need to know whether it's actually important for FEV1 at all. So, for example, we know we think we know what the minimally important clinical difference for COPD and FEV1 is, but then that said, you look at all the major COPD guidelines. How often do you target therapy against FEV1? And you'll see that at least the GOLD anyway has entirely abandoned FEV1 as a target of therapy since about 2012 or 2010. It's been abandoned. And so one of the little drums I bang on is we've got to be careful what we measure against in post-TB in terms of outcome studies. We don't want to make the same mistakes that other people have made in COPD and asthma, etc., etc. And so certainly diagnostically, I think it's important to do spirometry to see whether obstruction and airflow obstruction with or without reversibility. I think that is a very important time point. It's difficult to know. Again, it depends on what your major phenotype is. So if your major phenotype is a fibrotic restrictive disease, you maybe should be treating it more like you would an ILD with recurrent FVC measurements and follow-up. If it's got a lot of reversibility, then maybe intermittently would be warranted. Certainly in our clinic, we have the luxury of spirometry, so people get it at every visit. We don't do the full physiology, but I don't think it's necessary at all in that. I think diagnostically it's necessary, and if you have it, then probably maybe once a year would probably be worthwhile, or at a time point where you feel that there has been a deterioration, so you could measure, see if, say, the person's got exacerbated and come back to you or something like that. But again, it's a thin body of science that we're trying to base things on, and we make a lot of assumptions, extrapolated from other diseases, perhaps incorrectly. So yeah, so we don't know. Short answer.
That's really very helpful.
I think I just made a short answer long. Is that right?
Short answer is we don't know. I appreciate that. Thank you, Brad. That's really helpful and insightful as well. And another audience question, I said we'd have time at the end, but I'm trying to incorporate some of these audience questions that pertain to where we are. Celso, one of the audience members asked about bedside spirometry devices or some of these handheld spirometry devices. I know you've thought about it a lot. And the question was, any thoughts on the bedside or I'll say handheld spirometry devices for use in this setting? They seem to avoid, the question was, do they avoid use variability? But how useful are they, and are they really avoiding use variability, in your thoughts?
Yes. So my experience with spirometry is with the handheld portable devices. So these ultrasonic devices, that's what we have been using. In our experience, we don't have a lot of issues in terms of technical issues with devices, unless they fall or you have a really bad accident with them, you don't have problems. So that's what we have used, but I mean, it's very rare to find other clinics, even in the capital Maputo, that would be able to perform a spirometry. So probably this is not something that in other places in the country where you have a lot of TB patients you would have available, but having something with minimal technical needs or needs to repair or even less calibration is really important in our setting, and also needs to be handheld. I think the next, taking into account something that Brian said, having into account that you need to have training, I think the next step is to try to incorporate a little bit of AI into the different softwares that can really kind of coach you through a maneuver to make sure that people get the best curves they in each patient.
That's really very helpful, Celso. So it sounds like potentially they would be helpful. However, we also still need to know if it's from both of your answers, if this is really even the best test that we should be doing, or what to make of the test results afterwards. So that's really very helpful. Mansi, given the conversation on spirometry, please continue.
Sounds good. Thank you, everyone. All right. Well, I wanted to show our audience data from meta-analysis that was published in ERS in 2023 that included 14,621 patients with post-TB lung disease. And I most importantly wanted to show this forest plot and show how much variability there is in terms of spirometry results. And even within the same region, the study results have really varied, just to emphasize on the variability part here. All right, so I have another audience question here, which is, you decide to start this patient on inhalers due to persistent respiratory symptoms and moderate obstruction on her recent PFTs. Her MMRC score is 2, and she has had 1 hospitalization for COPD exacerbation in the last year. The question is, what inhaler would you start? If we could have our poll up.
Perfect. The poll is going right now. This is a fantastic question, Mansi. I'm excited to hear what our experts think. I think I know how one of our experts at least feels very strongly about this, and I want to throw him under the bus to begin with, and then I would love to hear also from the others. So we'll let people respond first, and then let's have a chat about this. And to the audience, thank you for your questions that are also coming in. Bhavna Seth asked a question which pertains to this exact question that we're going through right now. So hopefully you'll get a meaningful answer in just a second. Just 10 more seconds. Please feel free to respond. All right, Mansi, we have another controversial question here. 40% of your respondents said LAMA-LABA, 20% said ICS-LABA, 13% said triple therapy, ICS-LABA-LAMA, and 27% said LAMA or LABA. So you have really a smattering of all the above. Please, you can share your results, and then I think we have some good expert questions.
Yeah, and I think this is I think it's nice to have that controversy, and hopefully can our experts can give us more insight into it, given how with these symptoms and the scores that I mentioned, how do you what inhalers do you pick and why? And I also wanted to ask our experts here their thoughts on using inhaled corticosteroids in especially in post-TB bronchiectasis patients, given that we have some studies showing association between inhaled corticosteroid use and risk of pulmonary infections such as NTM.
Brian, I know you feel strongly about this. I'm going to ask you first, and then I'm going to ask Celso as well.
Maybe you should start with Celso.
actually, fair. Let's have Celso's answer, and then let's have Brian's long thoughts on this.
Yeah, I think Brian is more towards this question, but I will start my opinion. Like, I had the same answer like LABA Lama, having into account that will improve dyspnea, will improve exercise tolerance, and probably we can reduce exacerbations. In this case, I would, of course, be careful about the use of inhaled corticosteroids in a setting like ours, where you have a risk, and even when you think about comorbidities, where your risk of pneumonia or even NTM infections in patients with bronchiectasis is really high. So basically, I would at least have very specific criteria to use ICS in this type of patients.
Fair enough. Brian, thoughts?
Okay. Yeah, I think when I saw this question, I think the first thing that went through my mind is, okay, what am I calling this patient? What is the predominant phenotype? Do I think it's large airway disease, bronchiectasis, which can have obstruction, can have reversibility? Or do I think it's more a COPD, sort of TOPD, or small airways obstructive disease? In which case, yeah, so you've got to try and think which kind of pathway you're on, okay? Or both. You could potentially be a combination of both, for all you know. But in this particular, I hope you guys are not going to play this recording in 3 years' time, because I think in 3 years' time, what I say now will be entirely redundant. So, but in 2025, you're kind of playing it off and you're saying, okay, well, what are you doing? Are you treating bronchiectasis or are you treating COPD? Now, if you're treating, the rationale is that if you're treating bronchiectasis, the evidence for bronchodilators is not great at all. If you're treating COPD, the evidence certainly is better. And what you're alluding to here is that the patient is kind of analogous to a gold stage D, or E, whatever it is now, where you've got a kind of a frequent MMRC2 with frequent exacerbations, or a severe exacerbation. And so you would want to have maximum dual bronchodilator therapy. And so you've got to say, well, is that rationale correct? And I think in this particular patient, it probably is correct, because particularly if you look at your RB-TLC ratio, it is very high. And so it applies quite a lot of gas trapping, which I think is pointing to a small airway component. So I would be very comfortable with maximum bronchodilator therapy if you had it. In our context, it's really difficult for us to get our hands on LABA, and the majority of our LABAs come with ICS. It's quite difficult for us to unbundle our LABA from our ICS, because everything is on tender, which means it gets bulk ordered by the government. So, which brings us to what Jerry's alluding to is the use of ICS in post-TB lung disease. And I think there is equipoise, but the data in my mind at this point is concerning for the use of ICS in patients who've had previous tuberculosis. So if you look at the studies, there's quite a number of studies from North America, 2 from Canada that come to mind, 1 from, I think it's from the west coast of America, where they look at a lot of patients who have been put on ICS in the context. Some of them are registry studies and prospective registry studies. Those are the Canadian ones. And then there's the one which is also a systematic review of patients who have been on COPD trials. So it's not TB. They have been on COPD trials. I think it was published in the ATS, if I remember. It was either CHEST or the ATS. The Blue Journal. And they gave them ICS, and they showed an increased incidence of high burden contexts. So the majority of the sites that were actually included were from high burden settings. 22 sites, and only 2 were high burden TB settings. Now, in those studies, that not all of them showed increased incidence of TB. Some of them showed an increase in incidence of other mycobacterium, so NTMs and stuff. And certainly for me, that in our context in South Africa where we play, to give people who've already got structural disease and ICS is concerning. And I certainly go around stopping inhaled corticosteroids in patients with post-TB. There is a rationale, there is equipoise. We don't know if certain highly inflammatory phenotypes of bronchiectasis may benefit from ICS, but certainly there's nothing in the bronchiectasis literature that would suggest this is beneficial to date. So for me, the signal is against the use of ICS. I am concerned that in a percentage of patients, you may actually cause reactivation or reinfection, but a new episode of TB. And so I would tend to steer against the away from the ICS. The problem that we face is getting the bronchodilators without the ICS, and that's the reality we face.
That's fantastic, Brian. Thank you, and thank you very much, Celso. Also, this is great conversation, gentlemen. Thank you, Mansi. Please continue with your case and your thoughts.
All right. Thank you, everyone. So I'm going to move through this quickly for the sake of time, but I wanted to mention here that TB is a known risk factor for COPD. It has been mentioned in the GOLD reports. Also, we commonly see post-TB obstructive defect and air trapping, such as we saw in our patients. And really, the COPD treatment guidelines, the data comes from studies on chronic smokers, mostly looking at countries like United States and in Europe, and not from patients with post-TB lung disease. And in terms of post-TB lung disease, I could find one study which looked at inhaled Decatrol, which is a LABA for post-TB COPD, which was shown to improve FEV1 and reduce symptoms. But really, there are we need more studies in this area, as our experts mentioned. So coming back to our case, our patient cannot seem to catch a break. She now presents with an episode of hemoptysis and has coughed up half a cup of blood. In the emergency department, she gets a CTA of the chest, which does not show active bleeding. And actually, her right upper lobe cavity has closed. There is some bronchiectasis and fibrotic changes, which were there before. On her sputum smear and cultures, there is no growth, and her aspergillus IgG in the serum is negative, and she does not experience any further episodes of hemoptysis. So I wanted to talk about hemoptysis in TB briefly here, and mention that hemoptysis can happen not just in active TB, but also in as a part of post-TB sequelae. And this is data from a study that was published in India, showing that as many as 60% of post-TB patients presented to the emergency department with hemoptysis. A different study from South Africa mentioned that hemoptysis is the second most common cause of referral to a tertiary care center. And we know that hemoptysis is associated with bronchiectasis, with cavitary lung disease, as well as fungal infections such as aspergillus. And it is important to rule out recurrent TB as well as fungal infection and treat appropriately in these patients. And the further treatment for hemoptysis includes bronchial artery embolization or surgical resection of the affected area. Any other thoughts here on the hemoptysis part, Jerry, or from our experts?
Yeah, I think we'll talk about the hemoptysis, and then you can take us through to the end of the case as we have 5 minutes left. Celso, your thoughts? Are you all seeing hemoptysis in post TB, and how are you treating it? How are you handling it in some of these individuals? It seems like it's not an uncommon finding in post TB lung disease.
Yeah. So what in patients, I mean, part of these patients were able to kind of predict somehow, because usually are patients with a lot of cavitations. And this means usually at the beginning of treatment, they have been, or they had TB for a long time or extensive disease. So basically, we are usually, we expect in a few patients that they will have hemoptysis. Usually, therapy or treatment of these cases is conservative in terms that you usually see TB patients at a primary healthcare facility, that you don't have a lot of conditions for massive hemoptysis. So usually when you have a case where you have a really risky or high volume hemoptysis, you refer this to a tertiary facility. That is the approach. Part of the PTLD patients will come with a small amount or small amounts hemoptysis, and those are usually managed in a conservative way. I'm sometimes aware of patients that have a diagnosis of a second TB episode because of hemoptysis. So that's what we try to avoid. Make clinicians aware that not always is there's a second episode of TB, and associated to that, we are using GeneXpert as our main way of diagnosing TB. So in part of these patients, if you do a sputum test, you'll get positive DNA. So hemoptysis positive DNA is part of the time we take a clinician to retreat the patient without thinking about PTLD. In that case, you would be seeing a sequela plus reminiscence of DNA, because it's I mean in 50% of patients you'll still find a positive GeneXpert after 1 year of treatment. So I think people need to be aware of that.
Yeah, that's incredibly insightful, Celso. I think this retreatment pandemic for people who potentially have post-TB lung disease is why conferences like this and experts like you and Brian are necessary to spread the word that there is post-TB lung disease. It's not always a repeat case of TB. Mansi, in the interest of time, I'll ask that you go and let us know how your patient is doing now. She's been through a lot, and then I'll open to the experts just for a couple of closing comments.
Sounds good. Okay, so I'm going through to skip through some of the slides here, and come to the case conclusion. Our patient was recently seen on a televisit a few months ago, and she is actually doing quite well. She has had improvement in her respiratory symptoms after starting the inhalers, and with pulmonary rehab, she has not had any exacerbation in the last 2 years, and her surveillance sputums have been negative, and she is able to go back to work and spend time outdoors with her family, which is all great. So she's actually doing quite well.
That is fantastic. Thank you, Mansi. We have just about a minute or a little bit more left. I would love to hear from our experts any closing thoughts or things that you think would be helpful. There was one other question on eosinophilia, but I think please reach out to the experts as well. But any closing thoughts? I'll open with you, Celso, and then ask you, Brian, and then I'll close.
Well, I would just say that this case very brilliantly shows us that TB doesn't end with TB when TB treatment stops. Up to 50–60% of patients will stop TB but have post-TB disease. This is common even long after cure, and I think we have to do our part into having more data, trying to better characterize the patients and find solutions for all those patients.
Agreed. Brian?
Yeah, a great case conference, Mansi and Jerry. Well done, put together. I think the comment for me is it can be frustrating in the land of post-TB, especially for junior people, when there's so little evidence. But what you've got to realize is that 10 years ago, we weren't even talking about it. This time 10 years ago, we didn't even have a term. We didn't even use the term PTLD. It was just a mess. And so we are moving towards that. And there are so many questions that need answering. There's so much work that needs to be done to getting there. And we're getting there fast, considering how little we knew 10 years ago. it's amazing how rapidly the field is progressing. So don't get too frustrated. Recognize the complexity of post-TB lung disease and embrace the complexity and try and find a way through as we all do our work and try to research various aspects of it, and the answers will come. And hopefully they'll come sooner rather than later.
Excellent. Well, we've come to time. A huge, huge thank you to our experts, Dr. Khosa and Professor Allwood, and a very big thank you also to the organizers. Daniel, who's in the background, who you see on your screen now, helped us set this up. So we thank you very much for facilitating. And finally, thank you and congratulations, Mansi. What a wonderful case to help us discuss this. Thank you. Good morning, good afternoon, and good night.